Hello, everyone. My name is Kaylee Partita, and I'm a doctorate student of physical therapy. I am here to give you a presentation on pelvic floor therapy considerations for transgender individuals, including gender-affirming surgeries. On the behalf of the LGBTQ plus community, I'm only one person. However, thank you for taking the time to listen and be an ally to our patients. So the aim of this presentation is to offer gender-affirming terminology, themes, and practices to clinicians. One of the goals here is to bridge the gap between pelvic floor PTs and transgender patients with pelvic pain, pelvic floor dysfunction, what have you. A goal here is also to increase pelvic floor clinicians' confidence in treating trans patients at any point in their transition. I'm also here to emphasize how clinicians can positively impact the health of sexual, bladder, bowel function, and alongside with mental health in transgender individuals pre and post-op gender-affirming surgeries. I'm also here to discuss the different types of gender-affirming surgeries, complications, what to do, and also just to only graze the surface of what the LGBTQ plus trans community is dealing with, alongside offering resources for further education of clinicians and even patients or trans individuals who are having a difficult time navigating healthcare. Just a couple of ground rules. I'm wanting to discuss some quick terminology and considerations just so we're all on the same page. Yeah, so we're going to get right into it. We have what's called gender dysphoria. So gender dysphoria is basically pain and discomfort that trans people experience in regards to the anatomical incongruence. So it's going to depend on the person, and it's going to depend on their body parts, and it's going to come in at different levels. So it'll be case by case dependent with gender dysphoria. And I will get into why this is so important to know as a clinician later in this video. So we also have the opposite of gender dysphoria, which is gender euphoria. So that is satisfaction or joy caused when one's gendered experience aligns with their gender identity rather than the gender that they were assigned at birth. So this is very positive. They're feeling really at peace with their body, and they're like basically feeling themselves, feeling good and confident in their bodies. So gender is a spectrum, which is something we need to keep in mind when we are treating trans patients. So this spectrum includes a huge range of gender identities. Everyone's going to be case by case. However, I'm going to use trans as a very blanket term that includes intersex and non-binary people, just anybody who has that sense of gender queerness. Last two terms, we have what's called tucking. So that's basically someone positioning their penis and testes to reduce the outward appearance of a genital bulge. That way they have a more feminine figure, less masculine figure. So methods of tucking will include tucking it behind the legs, pulling it into the inguinal canal, and using underwear or a gaff that, there's different types of techniques that people will use. And then last definition, we have what's called binding. So I hate to use the word breast tissue here, but that is essentially what one is doing when they're trying to achieve that more masculine presentation. So they will compress breast tissue to create a flatter appearance of the chest. So moving right along, now you know certain terminologies that I will be using and referencing in this PowerPoint. So we have different types of gender-affirming surgeries. I'm going to try to move myself here so you can read it. Okay, so the list is endless. This is what the APTA has given us. Just I wanted to make it as simple as possible. But one thing you guys can look into is just different types of gender-affirming surgeries. The more you know how to support these patients, the better. So we have our masculinizing surgeries, and we have our feminizing surgeries. I'm going to go in depth with phalloplasty, scrotoplasty, and vaginoplasties. We'll touch on top surgery a little bit. Yeah, so you guys can read. I'm going to keep going. So in order to build up this presentation, I wanted to give trans people a voice in where the disconnect is with their care in regards to just making a medical transition and how hard that can be. So people were looking for more advice on aftercare. They're talking about their mastectomy, so they had top surgery. They didn't know how to take care of the scar, how to deal with corrections. They were only given really light terms on this from healthcare providers. So PTs, I'm going to get into how we can help these situations here. So clear instructions about the how and why of dilation. I think that's very obvious as to pelvic floor PTs. This is something we do day in, day out. So that makes a lot of sense as to where we can fit that role. And this third one here, sometimes I experience tough love with nurses and surgeons in appointments as unpleasant. This is not something that is, I just want to point out, this isn't something that's exclusive to the trans community. However, there are certain things that you need to be aware of what this community is dealing with in regards to existing in the world that doesn't understand us as well as we would like. So moving on to a more positive note, ever since my surgery, I mean, well, I've always enjoyed sex, but it's a lot more free. So I just thought that it was really funny. There's really good articles that just talk about the trans experience, and it's amazing the life-saving care that happens when gender-affirming care is emphasized. So this I used to help guide me through my decision-making process of what I wanted in this presentation and what I wanted to emphasize on moving forward. So we're going to discuss a male to female vaginoplasty here. So just to walk you guys through it, we have our corpus cavernosum removed. We also have our corpus spongiosum turned into a new clitoris. I think we need to make note that there is a neurovascular bundle here that is removed from penile tissue. So this this clitoris is going to be as sensitive as goal is for it to be as sensitive as regular cis clitorises. Moving along, we have our urethra here. We have our scrotal tissue a little bit changed into a labia majora. And the most neat part is we have a penile skin inversion here to make a vaginal canal. So we have our vagina, and then we have it placed alongside the rectum here. Going back to the post-surgical aftercare note, one of the reasons why it is so important to give these patients a voice is because 50% of trans respondents shared that they had to educate their health providers about gender affirming care, being that I had a vaginoplasty. This is just me making up an example, but it is genuinely patients are having to educate their providers on what it is that they have done for their medical transition. You had a vaginoplasty, what the heck is that? So there's so much time in care that is lost just because a patient has to explain what it is that they've done to medically transition. So 50% of patients are feeling like they need to educate their providers. 28% of patients are postponing seeking medical care because of anti-trans bias. It can come down to the microaggressions that trans people are facing in clinics. And then unfortunately, 19% of trans respondents refuse care due to discrimination. I didn't get further details on what this looked like, but discrimination is a really huge thing that this community is dealing with. So with that, we need to do our best to take care of them. Moving into a phalloplasty for our patients who are ready to bring their penises to life. Phalloplasty takes a couple of surgeries just to get from here to here to here. So breaking it down, our patients who have phalloplasty, they will have a muscular skin graft removed from forearm here. Sometimes it's from the leg, and they will then attach it to groin here. They'll make a urethra, so they have urethra here. It needs time to heal. So for the time being, they have a catheter placed still at the urethra. However, goal is to get them into the next step, which I will discuss here. But patient isn't able to pee out of their phallus yet, but that can change. So moving into the next section, we have our phalloplasty, urethral lengthening, and scrotoplasty phase here. So as you can see, our this this here was turned into this. So we have our clitoris embedded beneath the skin at the base of the phallus. We also have a testicular implant here. We have a new scrotum, and also worth noting that we have our urethra connected to our bladder here. So patients at this phase can now pee standing up. There is a third stage if the patient is so feeling to do so, where they can get a prosthetic placed and it can help them maintain an erection. It is worth noting that patients who have had phalloplasties, they have had they've been on testosterone, they have had their uteruses removed, they're not having periods. So just so you know, that's not something that needs to be on your radar when you're treating these patients. So moving right along, they can urinate while they're standing. Okay, so we are moving into preoperative considerations. So this is something I was reading about, and as pelvic floor PTs, we can really make a difference because 30 to 40% of patients prior to and after their vaginoplasty had pelvic floor dysfunction. So this is me kind of thinking out loud here. I couldn't find any research on this, but if people are feeling really dysphoric in regards to their penises, genitals, what have you, and they're tucking, I think that that could be a huge contributing factor as to why they're having pelvic floor dysfunction. So if you can address pelvic floor dysfunction before they have this huge surgery, you will find that you can make a positive impact on their care. So also, whenever your patient has bottom surgery and when they are in the hospital, what does getting up look like? How are they activating their transverse abdominis? What are they doing when they're having nausea and vomiting from anesthesia or pain medications or just pain in general? Because you guys, this surgery is no joke. So another thing we can do is optimize easy passage of urine and stool. I'm not even going to tell you guys how to do this because you know how to optimize urine and stool, rectal treatment, constipation strategies, toileting posture. The list goes on. I'm not here to tell you how to be a pelvic floor PT. Another thing to consider is dilation with patients who have had vaginoplasties will be lifelong, if not take a long time to get to that desired length of whatever the length is that patient and surgeon were aiming for. It's going to depend on them. But just so you know, dilation is going to be a lot more often than we're recommending for our patients who have vaginismus. We have about 30 minutes, 2 times a day, 20 minutes per day, 2 times, it really just, it is a lot. So one thing you can tell with your patients is with this dilator that you will decrease the risk for vaginal stenosis. So the patient who earlier was like, I don't know why I need to be dilating. This is a conversation that you have to avoid post-surgery complications. These surgeries aren't always covered by insurance, which is something that we're fighting for, but sometimes patients are paying out of pocket. So if we can decrease the risk of complications, we're doing so solid. Last note on dilation, doing a lot of reading. Dilation is sometimes done by pelvic floor PTs, which I commend the surgeons that are recommending that. Sometimes it's done by the surgeons who also, I'm sure, do a great job. Sometimes it's done by nursing staff. It doesn't depend. Anybody can be good or bad at their job. So who knows better for dilation than pelvic floor PTs? Moving on. So with post-operative complications, with our vaginoplasties, things that we can look out for is bleeding, tissue necrosis, and wound dehiscence. You guys know what that looks like. Wound dehiscence, just to remind you, is splitting of tissue. So that's something that is going to be on surgeons' radar. They're having really good follow-ups, hopefully. And then we're moving into the delayed complications of vaginoplasty. Complications can range from 0 to 0.8%, so it's not something that isn't common, but it is something that clinicians need to know about so we can screen for it and get them in with surgeon and maybe have to do a revision. So we have poor cosmesis, pelvic pain, granulation, tissue, neovaginal hair, bothersome urinary symptoms. We can rule in, rule out like what it is that is happening. We have like what's called urethral strictures, which is narrowed areas of the urethra. With urethral strictures, your patient will most likely report disrupted urine flow or difficulty voiding. So if they're not responding well to your care, that would probably indicate like just a nice follow-up with surgeon, maybe have some imaging done, see if there's a stricture. Also with prolapse, prolapse can happen. I couldn't find anything with pressure management and prolapse. Prolapse can just sometimes happen with the way that vagina was adhered to other organs in the body, and sometimes it just, prolapses. So moving into our fistula. So what is a fistula? It's a hole. Okay, so urine is coming out of my vagina, fistula, because there was a urethral reconstruction. If your patient's having a fever, just could be fistula. There is a really good article that goes more in depth into like why these complications can happen. I highly recommend it. If you need it, if you want to read it, ask me. I will happily send it to you. Moving into our phalloplasty, same thing. We have risk of urethral strictures, fistula, diverticula, which is the formation of a pouch in the urethra. Again, if patient's not responding to your care after a good few visits, no change in status, I would get them into surgeon's office personally. So you are treating patient post-operative. So this is where we can really do our diligence in being pelvic floor therapists. So it varies, but there is 0 to 72% of incontinence with people who've had phalloplasties, masculinizing procedures, and 90% of people that have had feminizing procedures, which is just reiterating the urgent need for pelvic floor PTs to get these patients into our care. Imagine how much we could decrease these percentages with regular follow-ups, pain management, all of that good stuff. Moving into our next statement here, people are having dyspareunia and painful intercourse after both different types of bottom surgeries, and our patients that have worked so hard to keep their vaginas not stenosing are having higher rates of sexual pain. So this is where we do our best in what we are trained in. So is it a hypersensitivity issue? Is it vaginismus? Is it stenosis? Are there bowel and urinary complaints? Moving back into the pictures I provided earlier, where will those surgical sutures be? Is it a scar mobilization problem? Can we dry needle it? I know that is something pelvic floor PTs love to do. And then with our phalloplasty patients, they have literally taken their arm, some muscle from their arm, and formed a penis. So we need to treat the full body of the person in front of us. So the donor site can either be from their arm, or the muscle graft can be from their arm or their thigh, but APTA definitely recommends treating this part of the body as well: strength, range of motion, sensitivity, all that good stuff. Patients who have had post-op surgery, like mastectomy specifically, How is their rib cage moving? How is their chest moving? What is their chest strength? How can we mobilize their scar, decrease scar sensitivity? And also, just pelvic floor PTs are very keen on what does the rib cage do to affect their surgery. So, uh, to affect their pelvic floor. So, our patients who have had mastectomies, how can we help them with the things I'm about to discuss next? Also, patients who haven't had a mastectomy and they're trans and they find themselves in your care and they are doing the chest binding, it's important to tell them and show them ways that they can move their body to reduce the risk of back pain, chest pain, shortness of breath, or overheating. Don't ever tell someone not to tuck or not to bind, but in fact, giving them ways to move their body and support their body in ways that they aren't, and in the times that they aren't binding or tucking or having dysphoria. Um, so this was something that really stuck out to me when I was reading through the articles. It wasn't on my radar until I started doing my own reading and trying to figure out what it is that these patients need from us. So there is what we call a little bit of a correlation between pelvic pain and testosterone hormone therapy. So what's happening is these patients are getting on testosterone therapy. We're getting increased sex drive, um, increased interest in sexual activities, and the ability to orgasm. But unfortunately, with this increased interest in orgasm, we're having vulvovaginal pain and discomfort in over 60% of trans men slash people who are taking testosterone therapy. 60%, over 60% people having pain with sex. So I did a lot of reading, and there are multiple reasons as to why this pelvic pain is happening in this community specifically. We have our physiolo physiology physiological our physiological reasons for pain. So we have testosterone associated vaginal atrophy, decreased lubrication, dyspareunia, vulvodynia, vaginismus, hypersensitivity to pain, screen in for endometriosis, look at their cycle history, pelvic injuries, dot, dot, dot. Pelvic floor dysfunction was a huge one on there. And also taking into account that there are psychological factors as well. Um, just like anybody having pelvic pain, it is multifactorial. However, it's important to note that with the trans community, there is a component of gender dysphoria. Unfortunately, this community also has really high rates of PTSD, history of sexual assault, or depression. Um, there is like a correlation between people who have pelvic pain and these same, psychological factors. So this is just something we need to keep on our radar as to why someone's having pelvic pain. You would do all of your screens to figure out why. So yeah, you know how to be a therapist. So another thing is we are able as physical therapists to recommend intravaginal estrogen cream for associated dyspareunia, vaginitis, and cervicitis. Also helping these patients increase their lubrication. It's the same concept of helping like menopausal women with vaginal dryness. It's the same concept. So less than 5% of trans individuals have tried this, and providers don't know that it's even an option. So they're going to a gynecologist. Gynecologist, I can't help you, and doesn't there. I'm trans. You're trans. I can't help you. It is that bad. Okay, so it can be. So providers don't know it's an option. Unfortunately, that's just where we're at right now. So another note on people who are on testosterone hormone therapy, there is a component of period pain, So this is not this I never want you to tell someone you're having period pain because of your gender dysphoria. Again, I just want this to be on your radar. So they may also be from the burden of feeling dysphoric about the mismatch between their biologic sex and their gender identity, which may manifest as pain or an amplification of pain that is experienced normal with ovulation or menses. So, with that being said, know that this is can be a reason in the list of multifactorial reasons as to why someone on testosterone therapy could be having period pain. Last note here, this isn't discussing cramps or period, or this isn't discussing periods or during sex. These cramping sensations are being reported by people who are on testosterone therapy. Most of them are reporting pain in the suprapubic region along with the fossa regions. So being able to do visceral mobilizations, pelvic floor releases, addressing pelvic floor dysfunction in general, hopefully we can see a decrease in those cramping sensations. So on our next note, you are aware of the surgeries, complications, people that have pelvic pain and testosterone use. Now you know how to treat them. It's a matter of how you treat them. So, in order to be an ally and a clinician who is aware of just trans issues in general, asking your patient how they would like to be addressed in terms of their name, their pronouns, how they self-identify with their gender. And also, this last note is something that not a lot of clinicians are doing. So, asking your patient what language should be used to describe their body parts at any point in their transition before you say this is what your vulva is doing, you can avoid gender dysphoria to the best of your ability if you ask these questions before you even mention a vulva, a penis, a boob, a chest, a breast, what have you. Hey, do you have something specific that you would like to call X, Y, and Z? Your patient will notice your effort. It is that simple, okay? So being able to be a safe clinician is everything. Find ways to encourage gender euphoria. There is a interrelation between gender identity and sexual orientation. So this is where things get really fun. What you can do is encourage your patient to have sex in affirming ways. How does sex look like to you in a way that you feel like your gender is being honored, affirmed, safe, what have you? Because gender is often expressed through sexual activity, we're here to establish an affirming environment. With that being said, researchers have reported that 80% of participants who are receiving trans affirmative care experienced an improved quality of life, decreased gender dysphoria, and a reduction in negative and psychological symptoms. All because you said, what are your pronouns? How do you want me to address you? What is your gender? What do you want me to call your body parts? Because we are in a field where we are referring to people's body parts, and that is how you create a safe space with your patient and build trust like that on day one. In order to be a safe space for your patient, you can let them know that you are working diligently to build them a network with providers that give gender affirming care and hooking those patients up with good peer support networks. So, hey, where did you get your like feminization surgery for your face? Where do you get hair removal? Like, and just building yourself a list. Patients are so happy to share. As a person in the queer community, I will share everything I know in order to keep my community members safe and happy and healthy. And the same goes for other patients. So we did all of the do's. Now we're going to talk about the don'ts. Don't assume everyone wants bottom surgery. If your patient is curious, let them bring it up. Um, at the end of the day, it is their decision. Definitely encourage the help of a psychologist, psychiatrist who also provides gender affirming care. Um, don't assume that people are unhappy or happy where they're at in their transition. You need to read those subtle comments and really get a gauge for where your patient's at and meet them where they're at. And don't assume outness in regards to sexuality or gender. It is incredibly scary coming out. So patients might not be out to their family members. They might not be out at work. They might not be out to people other than friends with their chosen families. I mean, this is really sensitive and you are a clinician who has their trust. So don't break the trust and assume that everybody is out. So yeah, these are quick and easy ways to be a safe space for your patients. Lastly, we have free resources for clinicians and patients. If you're a patient or somebody who's trying to navigate healthcare system, hello, I see you, and I want you to know that we're working diligently to provide you with the best gender affirming care. So this is what's called WPATH. It is basically the World Professional Association for Transgender Health. So a lot of my thinking through this presentation was um, guided by these standards. There is really good information on bottom surgery recovery, frequently asked questions in hospital stay for people that have had phalloplasties or vaginoplasties. There is so many really good resources online, but these are ones I found that I was really happy with. Since I am posting this video to YouTube, I didn't want to have photos of bottom surgeries. I didn't want this video to get removed, so there's photos here for phalloplasty and vaginoplasty. If you or someone you know is in crisis, this is the number to the Trevor Project. They have crisis counseling 24/7. This is really good for patients, providers. Um, and then if you're not in a safe space to call, you can message and get help that way by going to the website here. With that being said, I just want to say thank you for taking the time to be an ally. This presentation was made to honor the members in our community that have had shortened lifespans. May they all rest in peace. If you are LGBTQ plus, I want you to know that we are working really hard to provide you with the best gender affirming care. With that being said, here are my references. Please email me if you have any questions, comment on this video. Thank you.